All right. Welcome, everyone. Good afternoon. Thanks for joining us. If you don't know me, my name is Rachel. I'm part of the care team here at PPMD, and I'm really excited to be hosting this Lunch and Learn session today. My hope is that we'll have some folks continue to filter in as you have a chance to grab some food and hear all about steroids. So I think it's pretty obvious that the steroid landscape has changed a lot over the last couple of years. So I'm really thrilled to have three of my wonderful colleagues up here on the stage as we dig into sort of this new landscape, this new era of steroids and what it means for routine clinical care, what it means for stress dosing, for emergency planning, weight management. There's lots of implications, and we've got the right people here to dig into some of these questions and help us navigate this new landscape. I'm also going to give a shameless plug, and you're going to hear more about it from Dr. Weber, but we will be talking a little bit today about the new updated PJ's protocol. And so if you want to learn more or talk more about that after today's session, be sure to check us out at the care booth during the resource fair this evening. So without further ado, I'm going to go ahead and introduce Dr. Aravindhan Veerapandiyan, who is a neurologist at Arkansas Children's Hospital, and he's going to be talking to us a little bit about steroids.
Hey guys, good afternoon. All right. I know you all are eating. Do you have a question? No, she's holding the microphone. That's okay. You can hold it. That's okay. All right, we're going to talk about the evolving steroid landscape. I'm just curious. I see a lot of a mixed group in here. So, how many steroids that we currently use in the Duchenne space? Can anyone say that? Any guesses? No? That's good. Maybe 4. There are some steroids we use for the stress dosing as well, which we'll talk about. But yes, so the standard of care is 3. Good. All right. This is a small slide. I just want to see where we are now with the landscape in terms of multiple drugs getting approved, including our exon skipping and other therapies that are being approved. But I don't think we are there where the steroids wouldn't go away. I don't think steroids are going to go away. Steroids are still the standard of care as of today, and I think it's something we have to keep that in mind. And most of these clinical trials that led up to the approval for some of these drugs all had patients who were on corticosteroids. All right, so why corticosteroids for Duchenne? Oh, I could see here too. So I think back many years ago, we know that in Duchenne we have muscle inflammation, right? I think when you looked at the muscle biopsies under the microscope of these individuals with Duchenne, they saw some inflammation. So that's where the steroids came into play for because it works on the inflammation part, and that's why we use it. So since over the last couple of decades, we have a lot of research. There are clinical trials that are more structured, as well as a lot of what we call cohort studies, just long-term follow-up of patients that showed that corticosteroids are beneficial in the treatment of Duchenne muscular dystrophy by improving the muscle strength and function. We do know some of the ones that we've been using for long-term, like prednisone and deflazacort and Emflaza. They do prolong the ambulation or delay the loss of ambulation, right, for 2 to 5 years. They reduce the need for scoliosis surgery. You guys probably know now we are not doing as many of scoliosis surgeries compared to what we do many years ago. It also delays the onset of cardiomyopathy or the heart dysfunction in these individuals with Duchenne, and delays the need for the non-invasive ventilation from a breathing standpoint as well. And we know increases the survival. Now these individuals are living into 20s and 30s because of the steroids, as well as the multidisciplinary care the proactive care that we follow. So we talked about what are the corticosteroids. We said 3, which is you have prednisone, you have deflazacort, and then the most recent one was the Agamree. It was the difference between Agamree and some of the previously used steroids, the prednisone and deflazacort, is that if you guys look at the where there's a green circle compared to the red circle, there's like two bonds, like two lines. I think that is the difference in the actual structure of the steroid itself, and that actually makes AGAMREE slightly different. When we talk about corticosteroids, there are a couple of, we call it receptors, a couple of, the effects kind of split into two different receptors. You have the glucocorticoid receptor as well as the mineralocorticoid receptor. Steroids work on these two. The ones with the prednisone and deflazacort work only on, they don't work on the mineralocorticoid receptor, but the AGAMREE, which is recently approved, do work on that receptor, which is also a key difference that kind of plays into a role in the real world use. So what do these mean? Like, for example, if we are working on by working on this glucocorticoid receptor, it makes the anti-inflammatory action. It raises the blood sugar. That's why you worry about the high increased blood sugars and hyperglycemia. We check blood sugars on these individuals with Duchenne. It, again, behavioral problems. It elevates the mood and also alters the bone metabolism. The mineralocorticoid receptor is mainly with the blood pressure stuff, the sodium and potassium. Again, AGAMREE is the only one that actually has the action. It actually affects that receptor as well. All right, so just to briefly touch upon the effectiveness, what do we have so far? Kind of support the use of corticosteroids. This is a study about prednisone and deflazacort and placebo in individuals with Duchenne muscular dystrophy. As you could see here, they looked at two different doses of deflazacort, prednisone, those are in the blue bars, and then the placebo, which is sugar pill. And again, it shows there is improvement in the muscle function. Again, this is just sort of a long-term follow-up here. Again, the 52-week study was conducted in about 200 boys with Duchenne, and when they looked at up to week 52, the individuals on deflazacort performed better than those on prednisone in the muscle strength score. Then there are more observational studies. We kind of followed the individuals with Duchenne on the steroids. Again, they were followed up to 10 years, and deflazacort was associated with statistically significant preservation of function compared to prednisone. Again, this is all from long-term data that we have so far from the real-world use of these steroids. And then also more recently, there's also data presented at one of the conferences recently saying that deflazacort actually maintained the ambulation, meaning the ability to walk longer than the prednisone. Again, about age of loss of ambulation was higher in individuals taking deflazacort compared to prednisone. Then there's also data suggesting that the age at onset of scoliosis is delayed with the use of deflazacort compared to prednisone. All right. The most recent one is the AGAMREE vamorolone, which again being used in the maybe in the last year or so. So we don't have a lot of long-term data on this, but there are plans to continue to collect information on the long-term effectiveness as well as the adverse effects related to vamorolone. But the studies, you have to keep in mind that the vamorolone effectiveness study was mainly compared to placebo. It wasn't compared to prednisone or deflazacort. So vamorolone versus placebo, and we know they looked at two different doses, 2 milligram per kilogram per day and 6 milligram per kilogram per day. And the 6 milligram per kilogram per day, those actually improved motor outcomes. All right, so these are some of what we know so far in terms of the effectiveness of different steroids. Coming to side effects, when we talk about these different options, we always talk about the risks versus the benefits, right? We do know steroids do come with a lot of long-term side effects, but I think when you talk to your providers, there's going to be the actual benefits outweigh the risks, and it is going to be very individualized from one individual to other individual, depending on what steroid you choose, if you want to choose a steroid or not, dosing, and all of that. I'm not going to get into a lot of these, but we all know the side effects of corticosteroids, both short-term, meaning immediately you can see behavioral problems, weight gain, and that kind of stuff, and then long-term also effect on your bone, cataracts, and a lot of these things. And we're going to touch upon a couple of, the weight gain and a couple of other issues today from our endocrinologist. So when you look at all these three different options, if you look at, prednisone is not technically approved by the FDA, whereas deflazacort and Agamree are approved by the FDA to be used in 2 years and older. If you look at the actual FDA prescribing information, they just list all of the corticosteroid side effects as a side effect for all of these medications. Now, there are key differences. Each one of them is different, and there is, again, Agamree is also a steroid, but the key difference is what we know so far, and there are more learnings to be done as well. If you look at slow growth or short stature, we know deflazacort and prednisone both causes that, but vamorolone doesn't do that. It actually preserve the height in the individuals that we know of Duchenne. From a weight gain perspective, I think for a safety standpoint, vamorolone was compared with prednisone. We don't have direct head-to-head comparison of vamorolone versus deflazacort, but this is just what we know from our experience. From a weight gain perspective, it sounds similar to prednisone. Fracture, osteoporosis, we do know that vamorolone might possibly be better compared to your prednisone. And there are things that I've listed, delayed puberty, we don't know the data yet. And then from a behavior standpoint, vamorolone might be better than prednisone. Adrenal insufficiency, which we'll get into, we do know that vamorolone do cause adrenal insufficiency, and we do have to have stress dosing for that, which we'll talk about that. And with all of this information, there's still a lot of clinical considerations we talk about every single day when we talk to you all, talk to the families in our clinic, right? There is some information that we know. There's a lot more information that we don't know, and we still continue to learn. I know the Catalyst is doing a long-term study to get some more information on long-term effects of Agamree that would inform us also as we continue to collect data from that as well. Yeah, we don't know about long-term safety and effectiveness, which we'll continue to learn from that. Now, this mineralocorticoid effect, as if you guys heard about it, there are medications that actually work on mineralocorticoid that we use from a cardiac standpoint, right? Eplerenone or other medications, spironolactone. Now, can we use those together with Agamree? So again, there's no information. In the trials, those boys were excluded, but in the real world, we still use them, just closely monitor the sodium and potassium. And then, a lot of us use alternate dosing, meaning weekend dose and 10 days on, 10 days off, mostly in Europe, with prednisone, and some of them actually also use deflazacort weekend dosing, but we don't have information on vamorolone about that. So that's something to consider, keep in mind when we talk about options. And then vamorolone used with gene therapy. This is another thing that we keep talking about. As of right now, with the gene therapy, the steroids that we use around the time of gene therapy has always been prednisone. Now, can we use them as a standard? If someone is on vamorolone as a standard of care, can we dose them with gene therapy? That's you're going to talk to your individual provider depending on their comfort level and how it's being used. So these are some of the information that we have to continue to learn and collect as we use them in the real world. With that, I'm going to pass it on to Dr. Weber, and we'll take the Q&A at the end.
All right. Hello, everybody. Waiting a second for the slides to load. Okay, here we go. I'm Dave Weber. I'm an endocrinologist from Philadelphia. I'm so glad to be back here at PPMD. Super excited to be in Las Vegas, so thank you, PPMD, for hosting here. This is so much fun, and excited to talk to you all today. So my job is to cover all of endocrine and bone health in 15 minutes. So this is going to be a super high overview, and really going to focus on that new era. And for me, and for most of us, really, that new era is vamorolone, Agamree. So how do we think about implementing that in clinic? All right, so I'm going to show this in a slightly different way than Aravindhan did. So just thinking in the middle here of the individual with Duchenne or Becker or other muscular dystrophy, and I'm going to abbreviate that DBMD here, treated with steroids. So when we think about the classic steroids here, we think about how they affect growth. And the growth can really affect self-esteem, especially during those childhood years. We think about how they affect puberty, so delayed puberty also can affect self-esteem. It's also important to note that without that testosterone, if you're a boy, or estrogen for a girl, you really never get that last level of cognitive and emotional development, so that is important to go through puberty. Of course, sexuality and fertility also are impacted by testosterone. And then we think about osteoporosis. So this is one that many of you, I'm sure, have thought about or perhaps even experienced. So weak bones. And so that can present with the vertebral fractures, those backbone fractures. That can be painful. It can be a long bone fractures. A lot of times, unfortunately, it is a broken leg that sometimes leads to that loss of ambulation. And then there's the rare, but potentially very serious complication called a fat emboli syndrome, which can happen after a fracture, and that can lead to heart and lung failure and sometimes even death. Weight gain, my colleague Phil's going to mostly talk about this, but of course weight gain is tough. Anyone who's struggled with that knows it can affect self-esteem, but I think also important to know that it also affects mobility. And then really important is adrenal insufficiency, so I'll spend most of the talk going through how to manage that safely. Okay, so how do we think about these in the era of classic steroids? So classic steroids are deflazacort or Emflaza and prednisone. So this is what we've been managing for years. Both of these steroids really stop growth. You certainly have probably experienced that. We don't have a lot of good options to treat slow growth because of these. Some people will try growth hormone. That's another treatment. It's a daily injection. It just doesn't work very well. Delayed puberty. Most boys on daily Emflaza or daily prednisone will need help going into puberty. The good news is we can do that, and we can do that well. That means starting some testosterone around the age of 12 to 14. Some people do need to continue that for life. Others can stop it. Osteoporosis, we have some tools to help with this as well. So focusing on good calcium and vitamin D intake to protect bones. And then really thinking about getting started with a medicine called a bisphosphonate or another type of a bone strengthening medicine at the first sign of skeletal weakness. Weight gain, really tough. We talk about healthy diet, of course. Phil will give us an update on some weight loss medicines that we're now thinking about using. And then finally, adrenal insufficiency, again, perhaps the most important, education and having a stress steroid plan, which I'll talk about. All right, so now's our new era. So how does vamorolone change all of this? So the good news is that vamorolone really does not affect growth. And so what we've seen in the clinical trials and in the early clinical experience is that the boys treated with this, they tend to grow pretty much normally, or at least as normal compared to other people with Duchenne not on steroids. So that's great. Puberty, we don't know yet. The studies were done in younger kids, so we don't have enough experience in kids around that age of 12 to 14, so we're still waiting for more information. For osteoporosis, we think it's going to be better. The early information shows that the blood markers of bone turnover are healthier, and it looks like there's less frequent vertebral compression fractures. We don't yet know how it affects the long bone fractures, so the arms and the legs. Weight gain, unfortunately, isn't changed. So we've seen that the people on vamorolone still gain weight similar to prednisone, and that is actually probably more than what happens with Emflaza. So this can be a struggle in clinic. And then adrenal insufficiency, it's a little more complicated, as we'll talk about. All right, so now I'm going to really focus on how do we safely manage adrenal insufficiency and really highlight these updates to PJ's protocol, as Rachel mentioned. So hopefully most of you are familiar with PJ's protocol. It's a resource for you and for your clinicians. It really came out of a tragic situation of a young man with Duchenne who passed away, unfortunately, related to complications of not getting appropriate stress steroids after a fracture. It's been around for about 10 years, and we just recently updated it. And really, that update was to add in information for how to manage with vamorolone and talk about some of these other intermittent steroid regimens that some people use. And it's structured around 6 critical concepts that we're going to go through that I want you all to know. And then the protocol itself is very dense. It's really meant for your clinicians. We are working on a family-friendly version as well, but it does provide some very detailed examples for how to do stress dosing, how to do steroid tapers, and how to do steroid transition. So it should be a useful resource. All right, so I'm going to run through these 6 critical concepts quickly and then go through them in detail. So the first critical concept is that if you take steroids for more than 2 weeks, that's going to cause adrenal suppression. All individuals and their caregivers, their families taking steroids must recognize the signs and the symptoms of adrenal insufficiency. Everyone taking steroids must have a stress steroid plan. If stopping steroids, it is important to do this safely by slowly tapering. You need to continue to give stress steroids throughout that taper until a doctor has tested to make sure those adrenal glands have recovered. And then we want you to be very careful when changing from one steroid or steroid regimen to another. So let's go through this in a bit more detail. So steroids suppress the adrenals. Normally, our adrenal glands are connected to our brain through something we call the hypothalamic pituitary adrenal, or the HPA axis. When we take a steroid like prednisone or deflazacort or vamorolone, those adrenal glands go to sleep. And what that means is that when we have a stressful situation like an illness or a trauma, our bodies can't make that increase in cortisol that is needed to help fight that illness. So critical concept number 2, all individuals must know the signs and the symptoms of adrenal insufficiency. So the symptoms, so this is what you might feel or what you might see in your child, is a loss of appetite, nausea, vomiting, new weakness or fatigue, headache, stomach pains, maybe some new or different muscle or joint pain, some symptoms of feeling confused, and a sudden loss of muscle strength and coordination. And then the signs of adrenal insufficiency, these are things that your doctor would measure, would be things like a low blood pressure, a low blood sugar, or a change in the heart rate. If these develop, this is something worth talking to your doctor about. Number 3, everyone taking steroids must have a stress steroid plan, and this is probably the most important thing I want you to leave today with. So what is stress? I'm not talking about the stress of like a bad day of school or fighting with your kid or your parents. We're really talking about physiologic stress here. So things like fever, an illness that would keep a kid from going to school, some mild vomiting, mild diarrhea, a fracture that does not break the skin, or getting treated with a bisphosphonate and having some of the side effects of that. These are all what we call moderate stress. And then severe stress, this is that severe illness, right? So really significant vomiting, change in mental status, not really able to talk to you. If there's a car accident, a major trauma, a broken bone that pierces the skin, or if you have to have surgery requiring anesthesia. These are all severe stress. So what do we do about it? Well, during periods of stress, you need to take extra steroids. So this is the stress steroid plan. Importantly, if you take vamorolone, it cannot be used for stress steroid dosing, and that's because some of the slides that Aravindhan had said, it blocks the mineralocorticoid receptor, so it isn't going to allow your body to maintain a healthy blood pressure. So everyone on vamorolone needs to have a stress steroid plan with either hydrocortisone or prednisone. If you're on deflazacort or prednisone, there's different options. It may be safe to just split that dose into 2 doses a day. Your doctor can give you guidance on that. For severe stress, that situation of being very sick, this is when you need steroids through a shot, either into the muscle or into the vein. Hopefully, many of you people have an emergency steroids medicine like that at home. That's called Solucortef. If not, it's something worth talking to your clinician about. And then you always want to know your stress steroid doses, so have it in a letter, have it documented in the medical record or on an emergency card. Number 4, if stopping steroids, it's important to slowly taper the dose. So it is not safe to abruptly stop a steroids. First of all, you're just not going to feel well. You're going to have headaches, fatigue, nausea, just overall feeling icky. But it also increases that risk of getting very sick and adrenal insufficiency. And so your doctor should help you come up with a plan to slowly decrease that dose over the course of 1 to 2 months. Number 5, during that taper, you need to keep doing the stress steroids. So I told you that those adrenal glands, they really actually shrink down and you can't even see them anymore in the body. It takes 6 to 12, sometimes even longer for that time to recover. So during that whole period of time, you're still gonna give the stress steroids for illness. Eventually, your doctor, your endocrinologist, will check the recovery by doing either a morning blood test or something called an ACTH stimulation test. And once that's done, they can officially clear you of needing to take the extra steroids. And then lastly, number 6, be careful when changing from one steroid regimen to another. In particular, we want to be careful when we switch from a prednisone or a deflazacort to a vamorolone regimen. We recommend that vamorolone or the Agamree dose be started at the full treatment dose, which is 6 milligrams per kilogram. And that's because we've heard some stories of some people having some weakness and some nausea and some other symptoms if they start at a lower dose. And then anytime you're switching from one steroid to another, that's just a time to be extra aware of these symptoms. And if they develop, start your stress steroid plan and talk to your doctor. All right, so almost done here. So some takeaway messages. The endocrine and the bone health complications are serious, but the good news is most of them can be prevented or treated. Make sure you have an endocrinologist on your care team. If you don't, certainly talk to your doctor about it. Reach out to PPMD. They can help you find one local to where you live. Adrenal insufficiency is a potentially life-threatening complication of steroid use, but again, it can be prevented with education and appropriate planning. With PPMD, we've come up with a mnemonic called STRESS that just highlights some of these key takeaway message. So steroids continue, especially during illness. Remember to take extra stress steroids during trauma, illness, and surgery. Remember to always take your medicine as prescribed, so this is not a medicine you want to skip. Know those emergency signs of adrenal insufficiency and know when to give your stress steroids. Share the protocol so you know the stress doses and the other doctors know that stress dose as well. And then seek help immediately, especially if you have that severe stress of severe vomiting. That's time to get that steroid, come to the hospital, let us help you. And with that, I'm going to hand it over to Phil to talk about weight gain.
Somehow we always talk about weight gain over lunch. Sorry? All right, so I want to preface this by saying that although weight gain in muscular dystrophy has been known for a long time, there is increasing attention to this problem, and much of that has been driven by families who have raised a persistent weight gain as one of their top priority concerns. There is not much known about management of weight gain in Duchenne's or in actually other steroid-treated dystrophinopathies. But we can provide some background, some of the ways to think about this problem, what the community is thinking about in terms of interventions, and how this is changing a bit. So why is this important? So it's known that 50 to 70% of individuals with muscular dystrophy are affected with obesity by age 13. It's more prevalent, interestingly, in younger individuals with DMD than in older individuals, and we need to keep in mind that adults with DMD may eventually become underweight. Why is obesity prevalent? Well, there are obviously the same risks that are present in the general population: genetics, family history, the in utero environment, postnatal exposures, environment, and psychosocial contributors. But there are some things that are specific to muscular dystrophy and other steroid-treated disorders. So in muscular dystrophy, we see decreased resting and activity-related energy expenditure. There is decreased muscle mass, which decreases the resting energy expenditure. There is decreased mobility and decreased activity or other exercise expenditures. There is also, in general, increased caloric intake. Glucocorticoids contribute to hunger. Stress is, as you well know, associated with out-of-control eating for some individuals, anxiety, depression, boredom. Being at home all day is a risk factor for weight gain. In addition, we need to remember the social and cultural implications of food in individuals with chronic disease and their caregivers. For many families, food is joy. It's sharing it is family time. And so often families can feel that one of the few things they can do for their child is to give them the foods that they like. So these all contribute to increased caloric intake. And we also have change in body composition related to the glucocorticoids and decreased physical activity so that you get a body that has more fat and less lean or muscle mass. So what are the impacts of obesity in disorders like Duchenne's? Further decreased mobility. If you don't have strong muscles, carrying around a bigger body is harder work. There is increased risk to individuals being dropped, falling, and to the caregivers during transfers. There's an important impact on self-esteem and peer relationships. There's an impact of adiposity on bone quality. And in Duchenne, just as in other individuals, increased adiposity is associated with abnormal changes in lipids, glucose metabolism, and liver fat metabolism. So, a little background on obesity, definitions and guidelines, and I hope you can see this, but the current approach to the nomenclature in obesity now in kids now uses percent of the 95th percentile. So it's percent of the top percentile on the growth chart. So moderate obesity is 120 to 140% of the 95th percentile. And this can be determined using updated growth charts. Severe obesity is 140% or more of the 95th percentile. So just keep that in mind as you go through your journey with your family. In 23, the American Academy of Pediatrics updated their guidelines for the management of obesity in children and the development of comprehensive obesity treatment. And I just want to point out a couple of things from these updated guidelines that are relevant to your families. Essentially, the change is one that recommends a more aggressive approach to obesity in the pediatric population. In the past, there's always been hesitation to intervene. The kids just need to run more, they just need to eat better. But there's been recognition that we have failed to change the trajectory of obesity using these conservative approaches. And so current recommendations are a bit more aggressive. And for the obese individual who is less than 6, the AAP now recommends intensive behavioral and lifestyle intervention being delivered by a qualified care center. In patients who are 6 to 10, the same recommendation is given, but more strongly. It isn't consider referral to such a place, but refer to such a place. And most importantly, for those greater than 12, the AEP recommendations now recommend discussion of weight loss pharmacotherapy and bariatric surgery. So the question is, how does this apply to Duchenne's muscular dystrophy? What's happening? Okay, so how do we apply this? I don't know what that was there. Sorry? Make sure you're in front of the mic. Oh, sorry. Sorry, I tend to wander. How do we apply this to DMD? So what is comprehensive obesity treatment? The essential components of comprehensive obesity treatment in children and adolescents include treatment of obesity as a chronic disease. One of the things we often get asked is, well, if we start these medicines, we'll be able to stop it. This is a chronic disease. We don't stop blood pressure medicines. We don't stop cholesterol-lowering medications. So we need to change the paradigm to recognize that this is a chronic disease. And without major changes in the underlying circumstances, that obesity is not going to go away on its own. Secondly, it's important to partner primary care and pediatric weight management specialists. There is a need for intensive longitudinal treatment in a medical home. And for individuals with muscular dystrophy, the muscle clinic may be that medical home. It's necessary to evaluate and monitor medical and psychological comorbidities and contributors to weight gain. We need to identify and address social drivers of health. And we need to remember to use non-stigmatizing approaches that honor unique individual qualities. This actually sounds a lot like muscle clinic to me, honestly. This is much of what happens in muscle clinic. And finally, we need to use evidence-based targets for weight reduction and health promotion. Obesity has been plagued by a lot of emotion and presuppositions, and so we need to be careful that we are considering this in an evidence-based manner. And obesity is as amenable to evidence-based as any other medical problem. We need to then set collaborative treatment goals that are not limited to just body mass index or adiposity. We want to see resolution of comorbidities, dyslipidemia, prediabetes, diabetes. We want to be sure that we're promoting quality of life, self-image, and other goals related to holistic care of these individuals. And we want to integrate weight management components and strategies across all the disciplines. Treatment needs to be tailored and ongoing and address changing needs as the individual ages and their clinical circumstances change. We already do this in Duchenne's, right? So really what we need to do is be sure that weight management is part of this discussion with the team. For monitoring and prevention of obesity, it is now recommended that this be considered at every visit. In past treatment guidelines from PPMD, it was recommended that this be done at diagnosis, at the initiation of steroids, at loss of ambulation. But the current guidelines that are in development are now going to say this is something that needs to be addressed every time that the child is seen at muscle clinic, every 6 to 12 months. This is an ongoing intervention. We want to be sure that there is weight, standing height in the ambulatory individuals, and based on that, we can look at BMI, and we also want to consider motor function. In the individuals who are non-ambulatory, it's very difficult to get height, which causes problems in calculating BMI, so we recommend that you use weight as your primary measure. There's a need for a multidisciplinary approach at diagnosis and on a regular basis that includes nutritional guidance by a registered dietitian, psychosocial support, and individualized physical activity recommendations. And dietary counseling every 6 to 12 months that is family-centered, that addresses family meals, predicted meal times, limiting sugar-sweetened beverage intake, restaurant meals, and takes into account caloric expenditure based on the individual's level of physical activity at the time and not just their age and weight. Laboratory assessment should be repeated every 12 months and potentially more frequently, particularly after puberty, when most of these dysmetabolic or metabolic abnormalities begin to become more prevalent. Excess weight gain in the ambulatory individual is defined as a BMI greater than the 85th percentile for age or gender, BMI upward crossing of percentiles, or a BMI increase of more than 0.5 standard deviations in a year. These are all things that you can determine from the growth chart. In the non-ambulatory individual, increased weight for height or upward trajectory of weight percentile or Z-scores would be considered excess weight gain. Dietary recommendations should consider the dynamic state of energy expenditure during the life course of individuals, and total energy expenditure can be estimated using the routine height and weight that are equations that can calculate energy expenditure multiplied by a factor that takes into account the level of individual physical activity. And this has been shown to be valid in steroid-treated individuals. So briefly, what about weight loss medications? If we're going to start to think about intervening, we need to think about pharmacotherapy. Metformin, many of you are aware of, it's the first choice for oral treatment of type 2 diabetes. It is not FDA approved for any indication other than type 2 diabetes, though it is used in PCO. It is not approved for prediabetes, but it's often used in the absence of other successful interventions. It has minimal and unsustained weight reduction with significant variability, expected to be about 1 to 3% of body weight, and it does not prevent worsening of glucose abnormalities in adolescents. It may decrease risk of all-cause macrovascular cancer-related morbidity and mortality in the general population. It has gastrointestinal side effects that can be avoided by slow titration, but they can be problematic for individuals in wheelchairs, such as vomiting, diarrhea, etc. Vitamin B deficiency is unusual, and I know I'm running a couple minutes late here, I'm sorry. Lactic acidosis is incredibly rare, but potentially fatal. The combination of phentermine and topiramate is sold under the brand name Qsymia. However, it can be done as 2 generics, and it's extremely inexpensive. You can see here the amount of weight that was lost. This is placebo, and as typical in pediatric obesity studies, the untreated kids continue to gain weight. Those on phentermine and topiramate lose weight. These are not kids with Duchenne's. These are otherwise typical kids. So you see substantial weight loss. There is a weight loss on the order of 8 to 11% body weight loss, which is getting into the range of things like Ozempic and Trulicity that you see advertised on TV, and has a monthly cost of about $8. Next, GLP-1. These are the ones you see advertised: Ozempic, Mounjaro, etc. The GLP-1 is secreted upon ingestion of food in the stomach. It acts at the pancreas to promote release of insulin. It also acts to promote the suppression of glucagon, which contributes to elevated blood sugar. Most importantly, however, it slows gastric emptying so people feel fuller longer, and it has a central effect to promote satiety and reduce appetite. This is a pediatric study looking at the daily agent called liraglutide, and again, you see substantial weight loss compared to placebo. Here has a monthly cost of about $1,000. There's also significant treatment effect. This is typical for studies in obesity, and you can see all the way from substantial weight loss to even some individuals who gained weight. This is typical of these agents, and you don't know how somebody's going to do until they lose weight. This is Ozempic, again in kids, and we see substantial weight loss at a monthly cost of about $1,000. Finally, tirzepatide is a newer agent that actually is a combination of two agonists, and it has an even greater degree of weight loss. We're talking now in the range of 20% of starting body weight at a monthly cost of a few $1,000s. Gastrointestinal side effects are substantial. They are greater in general with liraglutide, although abdominal pain is quite common with Ozempic. Now, what are the DMD-specific considerations that we are starting to really think about? What are the goals of treatment? Is it weight? Is it adiposity? Is it quality of life? Pulmonary cardiac outcomes? Metabolism? Who's going to benefit? And from which interventions at what time? Targeting the right patient at the right time with the right intensity is a key of obesity management. Do we need intermittent treatment at time of highest risk? Initiation of steroids, loss of ambulation? Does it need to be chronic? Do we need to pay attention to the eventual loss of weight that often occurs as the individual's age due to progression of pulmonary and cardiac disease? And how about promotion of eating disorders? Are there side effects? Tachycardia and elevated blood pressure may be a risk for cardiac dysfunction and fibrosis. Topiramate can increase the risk for kidney stones, and GI symptoms are prominent with GLP-1 agents. Lean mass decreases by 25 to 40%. Is that a good thing in somebody with Duchenne's? Increased protein intake or exercise seems to be able to attenuate that, but how do we do that in individuals with Duchenne's? These studies reported the effect of weight loss on fat-free mass and not skeletal mass, so we don't really know the impact on muscle. Studies have not reported physical function following weight loss, and a decrease in skeletal muscle does not necessarily affect physical function. Weight loss improves the quality of the remaining mass by decreasing intramuscular fat, and so therefore there could be improvement. The studies are limited because of limited follow-up time, our limited ability to assess fat mass and lean mass. We don't have studies on impact of rate of weight loss. We have insufficient data on loss of muscle function after weight loss, and we have no studies in children. So, in summary, Rachel, obesity is prevalent in individuals living with DMD. Obesity has important impacts on health, care provision, and quality of life. It can provide an opportunity for substantial impact on health and quality of life for individuals living with DMD. Step one is recognizing that we have a problem. We need to incorporate routine weight-aware care from the time of diagnosis. Prevention is better than treatment. Early recognition of excess weight gain and initiation of intensification programs is better than trying to catch up later. And weight loss medications may be part of a multidisciplinary, multimodal plan aligned with individual health goals. Data individuals living with DMD are very limited, particularly regarding the unique risks that they may incur. Thank you.
Dr. Zeitler caught me checking my watch, but I wanted to make sure that we had some time for questions. So if you have questions, please come up to the microphone. There's nothing off limits, right? So questions about steroids, questions about bone health, questions about weight loss, weight management, nothing is off limits. So please come ask our panel of experts. And of course, I have a few to get us started as you find your bravery to come up to the microphone. So I think one of the things that I continue to kind of get tripped up with, Panda, is when I think about steroid classes, so different drug classes of steroids. And so I know that we talk a lot about how vamorolone or Agamree is like this non-classical, slightly different structure. If you had to summarize it in a very simple way, how do we differentiate prednisone and deflazacort from vamorolone?
Get a microphone?
Do you not have one? Good grief.
Sorry, I was sitting on top of it. Sorry, guys. No, so how I explain is, we have 3 steroids. It is still a steroid. I think that's the first thing I want to establish with our families. It's not a steroid, it is a steroid. And I think we talk about, I don't actually segregate as classic a novel steroid in my clinic. I just group them as steroids and talk about the differences between each one of them, what we have talked, how I presented. And it is going to be a decision that we make as a group, with the physician and the family, and it is going to be very individualized. It's going to vary from one individual to other individual based on their preferences, which, what they want to, what's their concern, and also I'm not a fan of switching to a medicine just because we have a new medicine available. Ask the question of why are we switching? What is the need? Maybe my son is worried about his height, then maybe think about switching to a vamorolone. So I think that's how I approach, to answer your question.
That totally answers my question. It really highlights the importance of that shared decision-making between you and your medical team. It's not just one singular decision, it's that collaboration where you're coming to that decision together, asking those questions, making sure that you feel completely comfortable and empowered with whatever decision you land on. Dominic.
Hi, Dominic Fullenkamp. I'm an adult cardiologist at Northwestern. I have a question. So on the GLP-1 agonist, we're prescribing these virtually every single clinic in the adult world to my patients with variable coverage of insurance. But I have not moved to prescribing these to my DMD patients because of the muscle loss concerns on any basis. Although I'd love to kind of ask you, are you actually prescribing these medicines?
Beginning to. I probably have maybe 5 kids on GLP-1s. I have more on phentermine topiramate, honestly, because we can pay for it. It's very hard to get GLP-1s covered, so we just have a little bit of experience with them. The GI side effects are pretty substantial, and the reality is a lot of these individuals already have substantial gastrointestinal problems. And so ultimately, whether these are actually a good idea for the guys with DMD, or I should say individuals with DMD, I don't think it's at all clear. And I don't think it should be done sort of widely at this point until we understand a bit more about how well it's tolerated.
Thank you.
Dr. Zeitler, do you see the loss of muscle mass when you use the topiramate and phentermine?
We've not looked. I mean, I assume, yes. I think you always lose some lean mass when you lose fat mass. The question is, what's the proportion that you are losing? And we don't know. But I would say that the most important thing actually would be to look at function. I mean, if you lose weight, okay, you lose a little bit of muscle mass, but if you can function better, then okay.
I think one of the things I just want to highlight is even for us is there's a lot of data out there. We have a lot of bigger centers actually using metformin as, they've been using that for years, but there's no data out there about it. I think when we use these in our clinics, I think this information needs to be disseminated so we all can learn from that.
I have a question. It's Niyati Prasad from Grunenthal. I'm the head of ClinDev. I have a question for Professor Weber, actually. So whilst you did have a plan for switching from prednisone to vamorolone or Agamree, what if patients need to switch over from vamorolone to another steroid or deflazacort? What would be the schedule, or would you taper from vamorolone, or would you think of sort of replacing it with an equivalent amount of cortisone? What would be the schedule for that?
Yeah, that's a great question. We aren't as worried about the switch back in that direction. So I think some of those issues with vamorolone is that unique property of the blocking of the mineralocorticoid receptor and what that might do in that transition. In the RPJ protocol, what we've recommended, if possible, is to switch to that full treatment dose of either deflazacort, so the 0.9 mg per kilo, or 0.75 of prednisone. Although we recognize that most older patients or people with Duchenne or Becker are not on those high doses. So I think if you're switching back from vamorolone to one of those other classic steroids, I think there's more room for individual judgment there. I think it's just most important that other way, going from a classic to vamorolone, to start the full dose, and then you can taper the vamorolone. So certainly we've had some of the patients on the high dose of vamorolone who've really gained a lot of weight, and then we sort of slowly can taper that down. But I think the key, again, is just educating families to just, during those transitions, look for any of those signs and symptoms. If they're having new muscle weakness or changes, reach out, add a stress steroid plan, and then think more about it.
Thank you. Thanks very much.
And the new PJ's protocol really goes into very technical detail as well to really provide some insight into this. And so that's something that's to be used, by your healthcare team in collaboration as a team, making these plans on how you want to switch and how you want to taper. But there's a lot more detail in there as well. So like I said earlier, come and see us at the care booth later, because we've got a whole bunch of those available for you to take. I think one thing, Dr. Weber, that you highlighted was the importance of stress dosing. So we know that that's really important. We talked a ton about it on our recent webinar that I thought was really helpful. But one thing that I always kind of forget that I would love to just talk about briefly is how long do you stress dose? So we've identified that there's either some moderate or severe stress. Maybe I'm sick, maybe there was an injury, maybe it's the Zometa infusion. How long do I continue that stress dose, and when do I know that it's okay to stop?
Yep, that's a question. So we typically recommend continuing it for 24 hours after that stress is gone. So if you have a fever on Monday and Tuesday, you'll then do that stress dose on Wednesday, and then back on Thursday, you're just resuming your usual steroid dose. If you ever have questions about it, that's a great thing to kind of reach out to your doctor to talk about, but that's the standard recommendation.
I think that's super helpful. And what about if I'm on weekend dosing? Does that change things?
Yeah, it's a good question. So we certainly expect to see less adrenal suppression for people on weekend dosing. This has not been well studied. It certainly is possible that there could be some transient or short-term adrenal suppression, like that next day after you come off of steroids. But I will tell you, in clinical practice, we just really haven't seen that much. So our practice, we don't typically have a stress steroid plan for people on weekend-only dosing, but we do educate everyone about those signs and symptoms. And if you notice that, wow, every Monday morning, my son just has a hard time getting up after getting those high doses on Saturday, Sunday, that's something to talk to your clinician about.
Awesome. Well, I see we are at time. Thank you everyone so much for joining. I hope that you found this session helpful, that you feel more educated now than you did at the beginning, and that you are armed with, what types of questions to ask your team as you think about decision-making around initiation or changing of steroids, how you manage your stress dosing, how you tackle things like weight management. I will say it a third time, forgive me. Please come and see us at the care table at the resource fair this evening. We're going to have not only the PJ's protocol, but the emergency wallet cards, other different, the Think emergency resources, all kinds of different things, so that you are completely equipped in times of emergency and illness, and you have all of the information at your fingertips to make great choices. So thank you to our wonderful speakers. We're really grateful for you joining us today, and we will see you back here in a few minutes for the official launch of conference. We can't wait to see you then. Thanks.